This lecture we will see about the health and family welfare program in India. It's just an introduction chapter. Health and family welfare program. Government of India has introduced the various health programs mainly to provide the basic health facility to all the citizens. How these health facilities will be reaching to all the citizens through the primary health care center. Main aim of the family welfare program is to improve the MCH services. MCH services nothing but maternal and child health services. They believe that the woman and the child are healthy, the country will be healthy, and also to stabilize the population growth and to implement the family planning and other counseling services related to the family planning and to regulate the interval between the pregnancies. They believe that the interval between the two pregnancies will in a manner to reduce the population and to improve the quality of life through the education, giving the good nutrition and the health and the employment. These all will empower the individuals of the India to improve their quality of the life. Before go to the topic, let us see the history or the milestones of the health and family welfare of the program. After independence, all program is highly concentrated to the mother and the child birth because the India's IMR MMR rate was very high. India is the first country to introduce the national program for family planning in the year 1952. But the year when they introduced, it was like a centralized approach. It was a target oriented approach. Both family planning they have introduced. What is they introduced? Like a permanent method and as well as the temporary method. That time they were introducing like we are many children were there in the family. If you take 10, 12, like that children were there, more children were there. Their family norm, they were telling that small family norm is the we are 2, we can have 3. 1977 and but all this program they were doing a research, continuous research in the community program. The beauty of all community health program is the program starting time will be they started to evaluate whether the program is going on right direction. Then the ongoing program will be evaluated. At the end of the program it will be evaluated. After the program also will be evaluated to find out the impact of the programs. That is the beauty of community program evaluation. Impact analysis they will be doing. What is impact analysis? Impact analysis is nothing but, for example, minimum need program. Example, you take one minimum need program or 20-point program. Any program they are implementing, they give sanitary water and basic needs to the community. The impact of it, the sanitation will be improved. How many percentage from the previous, the rest you can find out. But the impact of it, so many diseases will be reduced, like diarrheal diseases and other diseases will be reduced. That is the impact of the program. Yes, we'll come to the point. First, 1952, this is the India is the first country. They have introduced the family planning program. 1977, the program has been renamed as the family planning program to the family welfare program. You know, during these times and all, most of the deliveries were being conducted by the DAIs. So the DAIs and a lot of hesitation was there to do the IEC. We don't have the mobile phone, we don't have the internet, we don't have the television. So how the health education has to go, the public health workers has to go to the either in this program or in this program in these years. So health education mainly they were focusing on family planning. But then it is very sensitive to talk about the family planning and openly to tell about how to go for the condom and other method. Most of the time it had the failures, not a success. Yes, 1978 they have introduced one program is called EPI, expanded program on immunization. They were mainly focusing on vaccine against the 6 killer diseases. So during that time, if you see the communicable diseases are more people were dying. Even you take my father family, there are nearly 10 children born, only 3 was alive. Most of them died with chickenpox and other related illness in the before 1950s. They died like that. So what's happening in 1985, because of these past history, they started to introduce EPA. And then 1978 EPA introduced, 1985 they have renamed as Universal Immunization Program. This is like a universal program of immunization, UPI also you can tell. So there also they were started to covering this one. How this covering taken place? The universal immunization program has been implemented through the primary healthcare center and the sub health centers. Then still then you can ask me the main aim of the MCH services. The first objective we have seen. The main aim of the family welfare services is to improve the maternal and child health. You can ask me the question, and throughout this much impact was there, all this program, the child death has reduced. Obviously, it reduced, but not up to the expected level. Then 1992, the government has introduced CSSM program. That is Child Survival and Safe Motherhood program. In this Child Survival and Safe Motherhood program, they have added the immunization services also. The beauty of the Indian governmental program, they never neglect it. They either take a rename it or they revise it, they modify it, they continue until the goal is achieved. When the goal is achieved, smallpox we have achieved the goal. Polio we are striving to achieve the goal. How do we achieve the goals? Through this universal immunization program, EPA. Only this we are doing. Currently, Indradhanush program also there. So, Indradhanush is helping to door they are going and giving. So, we will achieve the goal really. But these are all the milestone. We couldn't achieve it. They were doing the research. Why we couldn't achieve this of the program? All these things. Main reason they found out that mainly DAI was conducting delivery. This mostly home delivery was conducted, and all this program, if you see the history, they were targeting only pregnant women and this one. But laterly they found out that anemia, when they found out they found out that MMR is not reducing because they target only the pregnant women. But the research is telling that the death is mainly occurring it is also one reason, the frequent childbirth is one reason, but the main root cause of the death is mainly by the anemia. So what the government has done, they have taken up the immunization program, they merged it into CSSM, but this Child Survival and Safe Motherhood program mainly modified to reduce the IMR and MMR, of course. And the research found out that anemia is the root cause of the maternal death. And also, as I told you, UPA is the part of the CSSM program. So, UPA is really helping to reduce this. Here, so the anemia is the root cause of the problem. Rather targeting the maternal mother, they started to target the adolescent girls. These milestones, adolescent girls were neglected. Only family, they were thinking. Why the adolescent girls? Adolescent girls are the future mother of our nation. So, in CSSM, they have found out through the research, then they have added into CSM before itself, they have found out why the failure of this program. Failure is not completely, we cannot say failure. The target was not achieved. And target, when I am telling, this all approach was a target-oriented approach. Right? Okay. This target-oriented approach. Then you can ask me, now if there is no target is there, you can ask now. No, excuse me. No, the scenario has been changed. It is not a target oriented approach. When the 1977, after CSSM 1992, there is a RCH program has been come. If you see all these previous milestone, all these approaches was centralized approach. And it was not decentralized, it was a vertical approach, and it is a target oriented approach. What is the failure target oriented approach? In 1952, when they set the target, they said that the one doctor has to do 10,000 of the family planning methods within this many months, or one ANM with this one they have to do. So what they have done, when they do the target, They will bring someone and apply copper tea them to them, and they will remove it and go. And then they started to even to give incentives when progress is going on. They started to pay the money and to welcome them for the family planning. That is also as a target. This much we have to complete it. Still, birth rate was not up to level expected level. It was not controlled. Currently, if you see RCH program, the RCH program are divided into two: RCH phase 1, RCH phase 2. And RCH program 1, 15, 10, 1997 to 2001. Here you might have seen Health for All by 2000 AD, that was the era. Health for All by 2000 AD, that was going on. And RCH package 2 was launched in between the 2001 to 2005. This RCH package was 2 is merged with NRHM. NRHM was launched in April 5th April 2005 by Dr. Manmohan Singh. NRHM was highly focused on 17 highly focused states. Correct? So this RCH package, from this RCH itself, the approach was totally different. The adolescent has been come into the healthcare services to reduce the maternal mortality rate, because they are the future mother. The scenario, if you see, there is a dynamic shift of the program from the RCH. What happened? Phase 2 especially, they have done it. And all these years, the health spend was 0.9%. You see, look at this amount. It's very less than 1 rupee. Less than 1 rupee. I will discuss where the other country, how they are. Let us finish how the programmal implementation was great changes, how I will discuss with you. The phase 2, there was a great change. There is a shift, I told you. What is the shift? There was a vertical program approach was there from centralized. You imagine anything, it was a vertical program. If a Delhi, 1952 or 77, Delhi is suffering from dengue, the dengue medicine will come to South India. But South India people will suffer from chikungunya and other diseases. So here totally they have changed the approach. It was a vertical program to the integrated service approach. Then you can ask me, now the drug is not coming from Delhi the same. No, it is decentralized service. Who is reaching the people? The health minister from the Delhi is not reaching the Tamil Nadu people, the people in the periphery level. The periphery level health workers, who are there? ANM is there, multi-purpose health workers are there. Right or not? So these health workers are empowered by the monetary benefit by the government. So they are directly involved, take a decision, send a vehicle to the family, pregnant woman. They are empowered to take the decision. They are not waiting for the chief or the primary healthcare doctor to give the order. So they do that. The vehicle has been given. So many vast differences in the approach has started to come in the RCH package too. It was so wonderful. And camp oriented approach was there. Then if you see the RCH package too, it was like a client oriented approach. Camp means they conduct a camp. They will have some medicine. Diabetic camp means only they will look into the diabetic medicine. Now every individual is unique. One have diabetic, one have hypertension, one have thyroid, one is this one. So they started that it is not going to a particular camp, we are not going to conduct. It is each individuals are unique and they are having a unique diseases. Various other health issues are coming in the current scenario. So they started to check the individual in a unique way. Then target oriented approach changed into goal oriented approach. So they set a goal. The goal is means it is achievable. Goal always smart, right? The goal should be smart. It should be simple, reliable, measurable, achievable, time bound, right? So this is the change. And the quantity oriented to the quality oriented. What is the difference between quantity? Quantity means it's a target. You collect somebody, you come, some agent will be there, dadas will be there, they will give someone and do the family planning. Okay, I give this much condom, this much this one, malady, this much people have given, finish it. But quality is we are coming and counseling with the DGO or the doctors or the nurse. Why you should have a small family norm? what is the importance of spacing the one children to another children. It's good for the mother's health. You take care of your health like that, you can give. Then it is a goal oriented approach too, and it is a the health education will go to their mind, and their quality of the life of the individual also will improve. Okay, then many other programs started to come. 2013 RMNCH strategy. What is RMNCH plus A strategy? It is a reproductive, maternal, neonatal or newborn or child and adolescent health. Child health plus adolescent health they have given much important. I will discuss it all these programs coming video. 2014 INAP India Newborn Action Plan to reduce the MR. Then 2018 Ayushman Bhavat program. Ayushman Bhavat program also this one. Then I asked you something. Why the health expenditure, if you compare, this was I told you till NRHM we could be able to send only 0.9% only we could be able to spend the money. It is less than, in the 100 rupees, less than 1 rupee, 90 paise only we were spending all these times. But after that, so many revolutionary changes, and Manmohan Singh has been increased to 0.9 to 1.75 and implemented NRHM program. NRHM also he put it that highly focused 18 states in a clear manner, and he created the cadre called ASHA. And the South India has done a wonderful, because this is a drastic change, double the amount plus it is coming. There was a great improvement in this one. Yes, but while comparing this amount, we also should know that health spent in the neighborhood countries. If you see 1952 onwards, less than 1 rupee we were spending, while that time Thailand is spending 2.7%, Malaysia is spending 2%, America and UK and other developed countries, it's uncomparable. They are spending 17.7, UK 18%. So currently how it is spending, you can ask currently. So 20 to 23 we are spending 1.95, whereas 22-24 nearly 2.22% we have come. About education also nearly 2.4% only we could be able to spend. Then there is a question. You can ask why, when China is spending 6.6, the population is also so high and heavy, and Brazil, they are not so big country, they are spending this much. Why India? It's $1 million question. Why India cannot spend less? What is the reason the Indian? Yes, the answer is the Indian geography. The India is situated in such a way, in a geographical area, in and around we have lot of enemies around them. So this 18%, whereas the developed countries are spending, we have to spend for our military people. So India is spending nearly 18% to the military people. We have to salute our military people, since they are saving our border. Since we are saving also, you know what happened in Kargil. Mostly China is trying to invade. Afghanistan is making a problem. Every country keeping an eye on India. So we have to strengthen our military power. Then it is not health is neglected, but we also could do wonders. You know what we have done in a COVID, like a mysterious nice work. We have immediately found out there is a good human resource in India to develop. The intellectual people are there. India is the platform to supply the doctors and nurses throughout the world. In that condition, we could be able to give and the cheap and best health care, but still we can spend lot of money. But currently the question is why we cannot spend. This is India can spend only for military 18% we are spending, because we have more enemies around in India. Human resource India is so beautiful. So you hope you understood my introduction about the health and family welfare program in India. This program is mainly launched to give every citizen in India to get the benefits. Main aim we have discussed, the milestones after the independence we have discussed. So next onwards In each program, we will discuss in a detailed manner. Thank you.